neck. The neck is divided into, this is the hyoid bone, which is a landmark, suprahyoid neck and infrahyoid neck. And please remember that larynx is part of the infrahyoid neck. So we have already covered that neck spaces. There is a concept of deep cervical fascia, which has got 3 layers: superficial, middle, and deep layer. And because of that, we can divide the neck into various layers. And so that is the main concept. Now, if you see here, this is a sagittal midline diagram of a human body, and you can see that the hyoid bone is here. Now, from here to here is the suprahyoid neck, and this is the infrahyoid neck. Now, the suprahyoid neck is divided into all of these spaces, which include pharyngeal mucosal space, parapharyngeal space, masticator space, parotid space, carotid space, retropharyngeal space, and perivertebral space. Now, masticator and parotid space we have already covered in the previous session. And each space has got, you should know what is the extent. Of course, you should know what is the location, then what is the extent, and then what are the contents. So we will revisit the details as we continue. So today we are going to learn about parapharyngeal space and pharyngeal mucosal space. Masticator space and parotid space, we have already finished them. Basically, masticator space is the one which is in purple color here. This is surrounding the mandible and the muscles of mastication. These are all the contents. You should know the extent. It goes all the way to the base of skull. Parotid space we have covered, and this green diagram here, green picture is the parotid space, which covers the parotid gland. These are the contents. Carotid space is a space which is from base of skull, from the aortic arch till the base of skull, and we will cover it subsequently. Then is the retropharyngeal space, which starts from down in the D4 vertebral body and goes all the way to the skull. And around the spine, we have got perivertebral space. Now, please remember that the vertebral body, etc., the bone itself, we don't consider it part of the soft tissue neck. That is spine, right? So, the soft tissues are divided into prevertebral component and paraspinal component. So the prevertebral component include prevertebral muscle. This is the prevertebral muscle where I'm pointing out, and the vertebral artery, the vertebral vein, the scalene muscles, brachial plexus, phrenic nerve. And paraspinal muscles are these muscles, this and this. Basically, I'm going to cover perivertebral space next time. But having said that, today we are going to learn how to differentiate whether a mass is in the retropharyngeal space, which is here, versus the prevertebral component of the perivertebral space. So that's why I went into a bit of details here. So this is the level at the nasopharynx. So first of all, you have to orient yourself. This is the nasopharynx. Nasopharynx is also what we call the pharyngeal mucosal space. So there is an overlap of terminology. Basically, the word nasopharynx, oropharynx, hypopharynx is traditionally used in anatomy and in also staging of squamous cell carcinomas, etc. But when we talk about the space concept, this mucous membrane, The inner mucous membrane is known as mucosal space. So the terminology, you should not be confused. There is an overlap of terminology. So in any case, if you want to call it nasopharynx or you want to call it pharyngeal mucosal space, you see this pharyngeal mucosal space, it's the same thing. So this is the nasopharynx. Now you have to concentrate that what is here, where I am pointing out, there is fat here. And this fat is parapharyngeal space. So we will cover parapharyngeal space shortly. Anteriorly, there is masticator space. And you can see that this is mandible. And then these are the muscles of mastication. Now, posterior to the parapharyngeal space here is the carotid space, the carotid artery and the internal jugular vein and the vagus nerve, etc. Now, here is the parotid space. And posterior to this, the one which is shown in this yellow color, this is the retropharyngeal space. And posterior to that, this space is the perivertebral space, and this is the prevertebral component of the perivertebral space. So this is an overview, and we are going to learn it once again shortly. Key point for you to remember is that look at the location of this parapharyngeal space. It's quite central, and it is considered a landmark. So we will remember this concept and take it further. So this is a coronal diagram which tells you that this is the masticator space which touches the base of skull. We have already covered it. And this space here is the parapharyngeal space. Repetition, that many of the spaces, they go and touch the base of the skull. And that is why if there is a tumor in the space or there is infection, it can go into the cranial cavity. So masticator space is this purple space and foramen ovale, carotid space and jugular foramen. We have done that. Parotid space and the stylomastoid foramen, from where the facial nerve comes out. And of course, this is the pharyngeal mucosal space. If we come slightly inferiorly, if you see this, this slice was at the level of nasopharynx. If you see here, so this is the slice which is number one here was the nasopharynx. Now we are going through the oral cavity, through the tongue. We are still in the suprahyoid neck. So if you see here, the landmark is the tongue. And you can see the anatomy changes, and this is the oropharynx. Look at the spaces. They're still there, but the configuration has changed. For example, look at the parapharyngeal space. It is now attenuated. It is not as big as it was before. And this is the masticator space. This is the submandibular space, the parotid space, the carotid space. Now, if we come to infrahyoid neck, this is the hyoid bone, and this is the infrahyoid level, at one level where there is thyroid here. So here there are 5 spaces: visceral space, carotid space, retropharyngeal space, perivertebral space, posterior cervical space. Key point to remember is that 3 of these spaces, carotid, retropharyngeal, perivertebral, they are present in infra as well as suprahyoid neck. On the other hand, the visceral space is only confined to the infrahyoid neck. Similarly, posterior cervical space is quite big in the infrahyoid neck. Technically speaking, it does continue in suprahyoid neck, but it is too attenuated. So we are going to leave this posterior cervical space, perivertebral space, and carotid space for the next time. So in infrahyoid neck, this is the level of the thyroid gland. You can see that this is thyroid gland, and this is trachea. This is esophagus. These are parathyroid. Now here is the carotid space. So there are many things within the visceral space. So part of the visceral space we are going to cover today. And please remember that many of these spaces, they act as tubes. So they go up and down like carotid space, the visceral space, the perivertebral space. They act as tubes. So they go up and down. Now, key concept in head and neck radiology is that whenever you see a lesion, first of all, you have to understand that what is the epicenter of the lesion. This is the key component. So if the epicenter, you diagnose the epicenter correctly, 80% of the battle is won. And epicenter will always be diagnosed on the basis of your anatomy. Remember that. Now, then you have to have a knowledge of your differential diagnosis. And depending on the radiological features and the clinical history, you can make a very good diagnosis or a differential diagnosis. Most of the cases, you will be able to give a single diagnosis. At times, there might be a differential diagnosis. So this is the beauty of head and neck. It's very rewarding that you can actually give a diagnosis. So before we go to parapharyngeal space, hyoid bone, as you know, is our landmark, very unique bone. So it is, it is a unique bone because it does not articulate with any other bone. And there is no other example like this in the human body. So it is sort of a floating bone in between the mandible, and here is the larynx, the thyroid cartilage. So look at this structure. So this is the body of the hyoid bone, and two names you should remember: the lesser cornu and the greater cornu. So this is the lesser and this is the greater cornu. Key point to remember is that there is a fibrocartilaginous junction. So there is a fibrocartilaginous junction here between the body and the cornu, and this will appear as a lucency. Don't get confused that it is something more than that. So, and many of the cases, there will be ossification here. So you might find a complete hyoid bone. Again, don't get confused. So this is the hyoid bone, which is our main landmark. Now, one of the muscles here, which is digastric muscle. So there is a concept of posterior belly of digastric, and then there is anterior belly of digastric. It's a very popular muscle for part 1 exam, particularly on MR coronal. We have already covered it when we were doing, oral cavity. So here you are. This is the orientation of hyoid bone. So this is the hyoid bone, and this is the thyroid cartilage of the larynx, and this is the thyrohyoid membrane. So this is the epiglottis. Right. So this was all a repetition or an overview of neck, and now we go back to parapharyngeal space. So parapharyngeal space, what is the extent? The extent is skull base to greater cornu of the hyoid bone. So indirectly, the parapharyngeal space does not go into the infrahyoid neck. Look at the contents. Practically, there is nothing, as far as the radiologist is concerned, there is only fat, because we won't be able to see branches of cranial nerve, free internal maxillary artery, ascending pharyngeal artery, pharyngeal venous plexus on regular imaging. So it is basically fat, and that is why it acts as a landmark for us. So once again, a repetition here that this is the parapharyngeal space, which has got fat. This is the pharyngeal mucosal space, the nasopharynx. This is the masticator space, which is anterior. So this is medial. This is anterior and maybe anterolateral. Now, parotid space is lateral, and the carotid space is posterior. So, as we go at the level of oropharynx, you can see that the parapharyngeal space is attenuated, and then it finishes. It finishes at the level of the the submandibular space. So, so this is on a coronal. This is how it can. You can see that it is in continuity. Point to remember is that parapharyngeal space communicates or it opens normally into submandibular space. So infections, etc., from the submandibular space, they can go up like this. They can travel. And please remember that parapharyngeal space also touches the skull base here. So I've already told you about Chapman and how to use it. The current chapter in Chapman's 7th edition, it is completely revamped, and we have used this concept of spaces. So it's a very good idea to go through that. As soon as you pick up any pathology, go through your Chapman and make your final diagnosis. So this is the concept. Parapharyngeal space is here. Masticator space is anterior. This is a generalization, right? But you have to stretch your imagination slightly, because at times this will be slightly anterolateral. For example, this is parapharyngeal space. A mass might be here, so this will be anterior. It might be slightly here, anterolateral. So if you see here, key point to remember is that in the center is parapharyngeal space. Anteriorly is masticator space. If there is a mass in the masticator space, it will displace the parapharyngeal space posteriorly. Parotid space is lateral. So if there is a mass in the parotid space, particularly, so if you go, you remember that in the parotid space or parotid gland, there is a superficial lobe and a deep lobe. So if there is a mass here, it will displace from the lateral side. So the parapharyngeal space or the fat will move medially. Carotid space is posterior. So a mass in the carotid space will displace it anteriorly. On the other hand, pharyngeal mucosal space, which is here, for example, as squamous cell carcinoma, it will displace the parapharyngeal space laterally. So, candidate 1, are you with me?
Yes, Dr. Khan.
Okay. Can you tell me what sequence is this? What sequence is this?
This is axial T1 and T2. I think the T2 is fat-satted.
Yeah, right. So in head and neck, we do stirs actually. So yes. It's a, the usual protocol for neck or head and neck is that we use T1 we did. Initially, we do a non-fat saturated because it gives, the fat is very well seen. It gives the anatomy very well. As far as T2 fat saturated, we don't do T2 fat saturated, we do stir, and it shows everything, every pathology as bright. And then we do, of course, post-contrast. When we do post-contrast, we will always do a pre-contrast fat saturated followed by post-contrast. Now, where is the epicenter? Now, there is a lesion here. Can you describe it and give me your final opinion? What is the epicenter of this tumor?
Okay, so there is a well-defined, predominantly hyperintense T1 and heterogeneously hyperintense T2 mass lesion, which is centered at the deep lobe of the right parotid gland. This displaces the parapharyngeal space and the nasopharynx medially with slight narrowing of the nasopharynx.
Mm-hmm.
So differential diagnoses are those of parotid origin, including pleomorphic adenoma. Differential to that would be a Warthin's tumor and malignant salivary gland tumors like mucoepidermoid or adenocystic carcinoma.
Right.
I'd like to look at the contrast.
Okay, fine. Now, so basically the answer to my question is that you feel that this lesion is in the masticator space, correct? Which space are you?
I thought it's the deep lobe of parotid, but yes, there is a bulk of the mass and the medial aspect of the masticator space.
Okay, so I take your point because the point is that I've just given you a single sequence, so you will be slightly, handicapped. But having said that, just on this, if we do our debate, if you see here, compare this thing. This is T1 weighted sequence, and look at this parapharyngeal fat. Now, where is this fat? It is completely obliterated. You don't see it. Now, so indirectly, this parapharyngeal fat, it is displaced posteriorly, at least one thing we can make out. Now, if you see here, this is pharyngeal mucosal space. The mass is also displacing it, to the contralateral side. It's not arising from it. Now, deep lobe of parotid, good point. I will take it because, you are just seeing a single sequence and you would like to see more sequences before you make up your mind. But it is actually not arising from the deep lobe. So, and please also remember, place yourself in parotid. This is parotid. So this, you see, this is the carotid space. This is the carotid space. If there was a mass in the parotid, it would have, it would have displaced it right like this. On the other hand, this mass has displaced the carotid space all the way, posterolaterally. So keeping this handicap in mind that you have got only a single sequence, this is a mass in the masticator space. So what is your differential? You did tell us your differential, but now I have placed it in masticator. What is your differential?
In masticator space, the most common lesion is an abscess. However, this appearance is not typical for an abscess. Other differentials include neoplasms arising from the muscles of the masticator, like rhabdomyosarcoma or other types of sarcoma, or lesions arising from the bone. However, I see the bone here intact. Neurogenic tumors is also a differential here, like schwannoma.
So it did enhance. The patient hasn't got any infection or anything, what we call clinically speaking. It was very well defined. It did show enhancement. So let's go back to Chapman. Now, if you see here, look at this 12.1 parapharyngeal space lesion. So it tells you contains primarily fat, right? Now, it lies between the parotid, masticator, carotid, pharyngeal. Primary pathology is rare. For example, this, right? So most commonly, lesions from other spaces bulge into or invade into this. And the same concept which I have told you. Deep lobe parotid neoplasm will widen the stylomastoid notch and displaces parapharyngeal fat medially. Masticator space displaces it posteriorly. Carotid space displaces it anteriorly. Pharyngeal mucosal space displaces it laterally. So, in our case, we have concluded that it is in masticator space. So then go to the second differential diagnosis from your book, which is masticator space lesions. So you were right that abscess is one of the most common, but clinically it was not abscess. Now, then bony lesions from mandible, no, it was not. Incidental benign conditions, these are usually, incidentalomas. So they are not, there was a tumor there, right? Now, motor denervation, no, it was not. Sarcoma, it doesn't look all that invasive. Perineural tumor extension. No, it was not. And then schwannoma of cranial nerve. There is a bit of a typo there. Cranial nerve, the mandibular division of the trigeminal nerve. So this is what it is. So the point I'm making here is that this example tells you the principles of head and neck radiology. First of all, place it and then look at the radiological features, the clinical features, and then reach a final diagnosis. So this was it. Now, let me go through a few DICOM images regarding our anatomy. So, candidate 1, can you see a CT scan? DICOM?
Yes. Yes.
Okay. So, now if you see here, we are looking for fat here, right? Now, as far as fat is concerned, you can see that there is fat here where I am pointing out. You can see my mouse?
Yes, Dr. Khan.
Okay, so if you see here, this is that fat which we were talking about. This is the parapharyngeal fat, parapharyngeal space and the fat. You remember the carotid space. So this is the internal, the artery, internal carotid, and this is the internal jugular vein. Now, this, on the other hand, is the parotid gland and the deep lobe. And you can see that it is sitting here. Now, this muscle is the pterygoid muscle, the medial and the lateral pterygoid, and this is anteriorly placed. And here is the pharyngeal mucosal space. So, let's trace it. Now, I have gone to the base of skull and I am coming down. We can see the nasopharynx here. You can see the fat here. And let's just concentrate on this fat. And remember, it will go till the level of the hyoid bone. And it is in continuity with the submandibular space. So here it becomes very attenuated. Then we lose it actually. We are unable to see, and here comes the submandibular gland. So if I trace upwards, initially it is very attenuated and then it becomes better visualized. So this is parapharyngeal space. You can also see it on a coronal, which is, but I'll show you an MR for that. The orientation of this coronal is slightly tilted, so it's not very well seen. Having said that, if you see here, and do you see it goes all the way here? You remember it touches the base of skull. Now look at this fat, and anteriorly it will go. So this is the oral cavity, and you can imagine that the submandibular space is here. So it communicates with the submandibular space. There is no, this is the submandibular gland. Now, let me show you an MR for this. So candidate 1, you can see the MR?
Yes.
So now this is a T1 weighted sequence and this is a T1 corona. So on this T1, fat is bright. So we are at the level of the nasopharynx, and you can see this fat here, and here you are. So this is the deep lobe of the parotid. This is the carotid space. This is the masticator space, and this is the mucosal space, pharyngeal mucosal space. Look at this fat and let's trace it downwards. And as we go down, you can see that this is the submandibular gland. This is the submandibular gland. I'm going to trace it upward once again. And from here onward, better visualized. But down here, it becomes quite attenuated. But the key point is that it communicates with the submandibular space. So on this coronal sequence, we can see this thing here, right? And you can see this, and this is the submandibular gland. So this is the parapharyngeal space. One thing in anatomy which I want to repeat right now is that this is the parotid gland. Candidate 1, there is a muscle here. What is this muscle?
Oh, sternocleidomastoid muscle.
No, you see this is
temporalis.
So let me orient you and then you will tell me. So if you see here, this is the mastoid process. You know, there is no signal here. Now this is the parotid gland. This is the deep lobe. This is the superficial lobe. Now there is a muscle which apparently is arising from the mastoid process. If you see here, and it goes like this, and it is still going. It is still going where I am pointing out. Actually, if you stretch your imagination, here is the hyoid bone. Now comes the hyoid bone. So it goes here and attaches with the hyoid. So over to you. Please name the muscle.
Stylohyoid.
Posterior belly of the digastric. Posterior belly of the digastric. Posterior belly of the digastric is an exam muscle in part 1. There is a posterior belly and there is an anterior belly. So if you see this coronal, look at this where I am pointing out. This is the posterior belly and this is the parotid gland. It will dip down and ultimately you might not see it when you reach the hyoid, but you lose it there. On the other hand, from the hyoid will be the anterior belly of the digastric, which ultimately is here. You see this thing? This is the anterior belly of the digastric. We covered it when we did oral cavity. So this is the anterior belly of the digastric. Right, now I am going to show you the case which you saw as a single slide. I am going to show you as a, it is not the same case, but it is the similar case. I think wrong case I have opened. Just 1 second, please. Candidate 1, I want you to scroll through it if you can. Try, ask for mouse.
Okay, I asked for remote control now.
I've given you. Try it, please. So there is a mass on left side, and orient yourself and describe. Go up and down. Describe which space this is arising from and what it is doing. How have you concluded which space it is? Go all the way to the skull base and come back and take your time.
Okay, sure. So here I'm at the skull base. I'm moving downwards. So there is a well-defined homogeneously isointense on this T1 weighted imaging sequence mass lesion, which is centered at the left parapharyngeal space with extension anteriorly towards the masticator space, and slightly indents in the carotid space, which is displaced posteriorly, and on the deep lobe of the parotid gland. The oropharynx here is displaced contralaterally with slight narrowing, but remains otherwise patent. So the lesion does not seem to be confined to either of these spaces around the parapharyngeal space, and I do see the parapharyngeal fat on this side, so it could be parapharyngeal or masticator.
So because of the displacement of the fat, you say that it might be arising from the parapharyngeal space, or it might be arising from the masticator space.
Yes, true. Yeah, the parapharyngeal fat is displaced at this point here.
So the point is that how rare are masses arising from the parapharyngeal space? What is the content of the parapharyngeal space? You remember I just showed you a Chapman slide for that.
Yes, mostly fat with a few nerves and vessels.
So very rare, isn't it? Can you? True. Okay, let me give you 2 more sequences, and now you are reporting this, right? So I will give you just 1 second, please.
Sure.
Let me give you this one, and then I will give you a coronal. So this is a stir axial, stir coronal, and let me slightly blow it up. Over to you.
Okay, so I'd like to scroll through the coronal view to see the extent of the mass in relation to the mandible and masticator muscles, because that's the most convincing space. Yeah, so the lesion is heterogeneously hyperintense, well-defined. It's extending all the way to the medial aspect of the ramus of mandible, with a non-visualization or poor visualization of the masticator muscles on the medial aspect of the mandible. The nasopharynx is displaced laterally, and the parapharyngeal space, as we saw earlier on the T1.
Okay,
so this
just 1 second. Go to stir axial and orient yourself. Go to the base of the skull on the stir. Yeah, you know, if you scroll through, these two will go together, right? They will scroll. Yeah. Continue.
Okay.
Up. Continue up.
Okay.
And correlate with the coronal now. What happened?
Yeah, the lesion
No.
No, it's moving, but sorry, it's moving, but it's a bit slow. Did it move to another sequence?
No, you have to give me the diagnosis here. I am just interested in the epicenter of the lesion, and I'm not interested in the pathology right now.
Okay, so the epicenter of the lesion is mostly in the left masticator space.
Very good, well done. Okay, let me take over. Well done.
Sure.
Now, so if you see here, let's go to T1 first of all. Now, this is the T1, and here one can have a debate that what is happening. So, as I am going from inferior to superior, let me make it slightly smaller. It is too large. Now it is better. So this is the pterygoid, one of the pterygoid. The second pterygoid, you don't see it. It is compare it here, and this pterygoid is completely replaced by this mass. Now the mass is here. So what it is doing is that, in a way, from the anterior side, it is completely compressing and displacing the fat posteriorly. I think what confused you is that part of the fat is here also. So the portion of the fat which was here is displaced here. The mass indirectly is not classical anterior, it is anterolateral. So it is displacing everything posteriorly. This is displaced to the contralateral side. Now, initially, we were worried if it is from the deep lobe, then we go more distally, more, and we rule that out. Now, if you go to coronal, this coronal is, go to your anatomy, and if you see here, actually, if you stretch your imagination, this is the cavernous sinus, and this is the stylomastoid, correction, the foramen ovale. It's not going into that, but on this sequence, we cannot rule that out without contrast. So the epicenter is in the masticator space. You see, even base of skull, please remember, parapharyngeal space will touch the petrous apex. This one will go here and touch the foramen ovale. So that is how you, if you, your anatomy knowledge really helps you that where of the masticator space. I showed you the differential diagnosis, and this is how you diagnose in head and neck specific tumors. Okay, let's continue. Okay, so we candidate one, can you see this program? Please note.
Yes.
Okay. So I've already made the announcement about whatever is written there. So now this is pharyngeal mucosal space. So pharyngeal mucosal space indirectly is the pharynx. So as I've told you, it's a synonym. And so basically it is the airway side of the nasopharynx and the oropharynx. And look at the contents, the lymphoid tissue. In the nasopharynx, there will be adenoids. In the oropharynx, there will be the palatine or the phaseal tonsils, and the lingual tonsils, which are sitting on the tongue. Then there are muscles there. We, as radiologists, we are not much bothered about them. We don't see them very well because they are very thin. Superior middle constrictor muscles and other muscles. There is pharyngobasilar fascia, etc. This levator palatini muscle. Torus tubarius is this thing where I'm pointing out. This is the eustachian tube, and here the eustachian tube, it opens here, and it is defined as the projecting posterior tip of the pharyngeal opening of the eustachian tube. Cartilaginous, it opens here. We'll come back to this. Now, if you concentrate on this, this is midline sagittal, and you should have a clear-cut idea about the term pharynx and the parts of pharynx, and how do you discriminate it with surrounding structures. Now, this is the nasopharynx, then is the oropharynx, then is the hypopharynx. So posterior to the nasal cavity is the nasopharynx, posterior to the oral cavity is the oropharynx, posterior to the larynx is the hypopharynx, also known as laryngopharynx. In many anatomy textbooks, you will see that word. It is the same thing. So you should have a clear-cut idea what are the boundaries and how do we define that. Now, first of all, please remember the nasal cavity is sitting here. So this is the palate. There is a hard palate and a soft palate. Now, if you draw an imaginary line from here, perpendicular to the spine, superior to that will be the nasopharynx. And here there is opening of the eustachian tube. Now, you have to have very clear-cut idea of discrimination between the oral cavity and the oropharynx. Actually, we did it previously, but I'll revise it today. So this is the oral cavity. In the next few slides, I will tell you the boundaries between oral cavity and the oropharynx. So posterior to that is the oropharynx. And this is the hyoid bone. Now, this is the epiglottis. And from here till here, this is the cricoid cartilage. This is the larynx. So inferior to the level of the oropharynx, from here till here is the hypopharynx. Please remember that esophagus, anatomy textbooks will tell you that it starts at C6 level. So the hypopharynx or the laryngopharynx then is in continuity with the esophagus. And so this is the cricoid cartilage. Posterior to that is the post-cricoid portion of the hypopharynx as well as the esophagus. Radiologically speaking, you cannot discriminate where hypopharynx has ended and esophagus has begun. But generally speaking, C6 is the landmark. So if you see here, now we have to concentrate on how do you differentiate between oral cavity and oropharynx. So this, whatever is blue here is the oropharynx. So what are the boundaries? This is the hard palate, this is the soft palate. So the soft palate per se is part of the oropharynx. So, and superior to this level, because it gives you this drooping type of appearance, superior to this level, so this is the level which is in line with the palate, hard palate. This thing is the nasopharynx. Now, first of all, the boundary between oral cavity and the oropharynx. So if you see, this is the tongue, this is the oral tongue, which is visible when we do a clinical examination. And this portion is known as base of tongue. Do not confuse the term base of tongue with root of tongue. Root of tongue is inside the tongue here. We did cover it in oral cavity. So this is the base of tongue where the lingual tonsil is. This is the epiglottis, which is part of the supraglottic larynx, and inferior to this portion will be the hypopharynx. So now these are the landmarks to differentiate between the oral cavity and the oropharynx. This is the tongue. These are the taste buds, which are circumvallate papillae. And so posterior to the circumvallate papillae, all of this is the lingual tonsil. This is all part of the oropharynx. If you see here, these are landmarks, these are tonsils. From the tonsils, there are muscles and mucosal folds here. This one is known as platoglossus arch, and there is a muscle there, platoglossus muscle also. Also known as, a easier name to remember is anterior pillar of the tonsil. So this anterior pillar of the tonsil is the boundary between oral cavity and the pharynx. The pillar itself is considered part of the oropharynx. So this is anterior pillar, circumvallate papillae. This is all oral cavity. Posteriorly, this is base of tongue on which lingual tonsil is sitting, and these are the palatine tonsils. Now, if you see this diagram, again, this is the oral tonsil, this is the anterior pillar, and so this portion has to be the oral oropharynx. On an X-ray, this is how it looks like. Of course, here I've selected a case in which there is an air column. It is not a must that you will see an air column like this. So we can see that this is the nasopharynx, and here you can imagine has to be the oropharynx, and this is the epiglottis. So from here to here, this is the larynx, and from here downwards, hypopharynx and the esophagus. So 1, 2, 3, 4, 5, 6. So this is C6 level. From here downwards will be the esophagus. I'll show you a barium solo examination, and then we will take a break. So this is a barium solo examination. And this will also tell you that, so candidate 1, you can see a barium solo?
Yes.
Okay. So if you see, this is a barium solo examination. This is a lateral view, and just to give you the anatomy. So there is air here, and this is nasopharynx. You can see barium sitting here in the oral cavity. The patient has taken a sip. Look at this. This is the hyoid bone, and then this is the hyoid bone. This is the C6 vertebra, and this is some calcification or ossification of the laryngeal cartilage. So now the patient is about to swallow. Just concentrate here and see what will happen. So as the patient is about to, you can see these are the muscles of the soft palate, and what they are doing, they are rising. You see this? It has caused complete obliteration of the passage between the nasopharynx and the oropharynx, and it has caused obliteration here. And otherwise, what will happen that if we swallow like this, the food material will go into the nasal cavity. So this is the role of the soft palate. It has closed everything, and then you see the bolus is going down, and it doesn't go into the trachea. Why? Because of the epiglottis. So just concentrate on the epiglottis. This is the epiglottis. This is the larynx, and see how it is going to cover it. Here you are. So the muscles, they, the constrictor muscles, etc., it raises the pharynx superiorly, and it obliterates this air space. You see, this is completely obliterated, and then the bolus goes down. So let's see it in fast motion. Here you are. Do you see? Complete obliteration, everything, and then it goes down. So this is how we swallow. So epiglottis is the lid of the larynx. candidate 2, can you see this barium solo slide written?
Yes. Yes, sir.
Okay, so this is an MR, and a sagittal MR which tells you that this is the epiglottis. So this is the hard palate. This is the soft palate. So of course the soft palate, because it dangles like this. Otherwise, if you draw a line like this, superior to that will be the nasopharynx. From here till here will be the oropharynx, and from here downwards will be the hypopharynx. On a CT scan, similarly, here the landmark is this epiglottis, and this, of course, is the oropharynx. This is the nasopharynx, and this will be the hypopharynx. So the pharyngeal mucosal space, which is the nasopharynx, it touches the base of skull, which is common sense. Now this is it. If you see here, this is the nasopharynx, and anteriorly this will be the nasal cavity. So this is the torus tubarius, which is the cartilaginous portion of the eustachian tube, which opens here. This fossa is known as fossa of Rosen-Miller, and you can see the pharyngeal mucosal space sitting here. You don't have to worry about anything about the names of the muscles, etc. You don't see them, but it's a good idea to have a general concept that within the mucosal space, which is indirectly the wall of the nasopharynx, of the pharynx, you've got muscles also. These are thin muscles: superior constrictor, inferior constrictor, middle constrictor, etc. And there are other concepts here which I will skip because these are beyond our mandate today. Pharyngo, basilar fascia, etc., which you don't need to worry about that. Now, a repetition of what we learned. Look at the boundary between the oral cavity and the oropharynx. Now, this blue thing is the oropharynx, and the palatine tonsils are sitting inside. So this is that anterior pillar. Anterior pillar is the boundary, but it is part of the oropharynx. This is the anterior pillar, and these are the circumvallate papillae. So posterior to that is the oropharynx. All of this is oropharynx. If you look carefully on this diagram, you see where I'm pointing out, these are muscles, right? So these are superior pharyngeal constrictor. You don't have to worry anything as far as radiology is concerned, but you should know that muscles are part of the same space. Here we have come slightly below, and we can see the hypopharynx here. We'll come back to this, don't worry about this. Now, orient yourself, basically orient yourself at levels. So we are going through the pharynx now. This is what I call the level 1 or the nasopharynx level. So if you see here, the slice is going through it. The hard palate is, or the soft palate is not included here, right? So this is it. So at this level, the slice is going like this. This is the nasopharynx, and this is the eustachian tube. And with the eustachian tube, of course, this is the fossa of Rosen-Miller here. So this is nasopharynx. Next level. This is the next level, which is the level 2. Here, it all depends where the slice is going through, but you should not get confused. Because this is tongue, you can imagine that the soft palate is dangling like this. So part of it will go, the slice will go through soft tissue. Anteriorly, there will be a bit of air, and then there will be the hard palate. and it gives you this confusing appearance. It all depends in your patient and how the slice is oriented. So don't get confused. So this is the slice, and this is the soft palate, the uvula here. Portion of the air, which is the air in the oral cavity, is visible here. This is the alveolar ridge of maxilla. Now we are passing through the tongue, the oropharynx or the oral cavity level. And you can see that the slice is not passing through the soft palate. Slice is not passing through the epiglottis. So these two are sort of something which are projecting into the airway. And now this is the corresponding axial slice. So this is the level, and you can see the tongue here. Now on the tongue base, if you see here where I am pointing out, you can see that the density is slightly larger, slightly brighter. So this is the lingual tonsil. And on MR, particularly on the stir sequence, this will be high signal. This is the lingual tonsil, and anteriorly is the tongue. Because tongue has got a bit of fat, it appears low density also. And the palatine tonsil is just coming into view. So this is the oropharynx and the submandibular gland. Here there is a muscle which is the longus colli muscle. It's a landmark muscle, and we will come back to this later on. So now look at this. What is the difference? We are passing through the epiglottis. So here we are passing through the epiglottis, and how will it reflect? It will reflect like this. You see, look at this slice. So portion of the epiglottis is here. This is the free margin of the epiglottis. And anteriorly, look at the lingual tonsil, which is the base of the skull. And this is the oral tongue. Next slice, level 5. Now what has happened? This is veliculi, or the velicula. There is right and left veliculi. That is the level. So what happens is that the epiglottis here is connected to the hyoid bone. How is it connected? It is connected via a midline structure which is known as hyoepiglottic ligament. And on the hyoepiglottic ligament, there is a mucosal fold. We call it glossoepiglottic fold. I will revisit this shortly in diagrams. But point to remember is that the glossoepiglottic fold is a midline structure, and it is connecting the epiglottis with the hyoid bone. And the air space is divided into right and left side. Each side is known as velicula. So this is how it looks like. And this is an exam type of a scenario, particularly part 1. So you can see this is the glossoepiglottic fold. Right side, right velicula, left velicula. And this is the epiglottis. By definition, please remember, veliculi are part of the oropharynx, and they are not part of the supraglottic larynx. So remember that. We will revisit this shortly. Now, anteriorly, you can see the hyoid bone, and this is the hypopharynx. And you can see these sinuses on the right and left, which will be better seen on the next slice. So you see the slice is going like this. Another point, if I go back to remember, is if you see there is a bit of low density, the windowing here is close to bone window. You can see this low density. And this is epiglottis. So point to remember, anterior to the epiglottis is fat, and we call it pre-epiglottic fat. It's a landmark type of a thing, particularly on laryngeal imaging. So let's go to the next slice. So now we are going through this fat, right? So this is the epiglottis, and we are going through it. And what has changed? You can see that there is fat here, low density. hyoid bone is visible. And if I go back, the previous slice was this one, glossoepiglottic ligament, veliculi. Now this slice converts it into a single airway. This is supraglottic larynx. And anteriorly, the fat is pre-epiglottic fat. Pre-epiglottic fat, by definition, is part of supraglottic larynx. And glossoepiglottic ligament, on the other hand, which was a slide before, will be the boundary between the two structures, supraglottic larynx and the oropharynx. So now we go. So the point is that we are going to revisit this. So don't worry if you have not understood this. I'm going to teach you this quite a few times once again. So this is pharyngeal mucosal space lesions in nasopharynx. This is from your Chapman. And I think the most important one is the nasopharyngeal carcinoma. And it has come in the exam where they have shown an MR. I'll show you today also of a neck swelling. And this is what happens in real world also. So beware about it. A patient will present with neck swelling, which will be a lymph node. And there will be unknown primary type of, hidden primary, and the primary will be in the nasopharynx. So that becomes a sort of important case for your day-to-day radiology also. And this is second differential diagnosis, pharyngeal oropharynx. And in this oropharynx, the most important ones, other than SCC, is of course inflammation. This is, for me, this is for your 2B, this is the most important. So the concept of displacement of the parapharyngeal space. So this diagram tells you if the lesion is sitting here, this is the parapharyngeal space, and the fat will be displaced laterally, which is common sense. So this is from StatDX, enhancing squamous cell carcinoma. And the main point is that you see the mass is this, and it is displacing the fat posteriorly and laterally. So now we will see an MR, and we will also see an abnormal case. Candidate 2, can you see my DICOM viewer?
Yes, sir.
Okay, so this is a T1 weighted sequence, and let me slightly make it bigger, yeah. So this is a T1, and this is a stir sequence. Our aim is just to concentrate on the airway and nothing else. Now, when we go superiorly, this is the nasopharynx, and we can see that there is a bit of adenoid, slight bit of prominence. And if you see, develop your eyes on this one, on stir sequence, look at the, the lymphoid tissue and see how bright it looks like. And that is the beauty of a stir sequence. So all lymph nodes, they will be bright like this. Lingual tonsil, palatine tonsil will be bright like this. Of course, if it is abnormal, again, it will be bright like this. Size criteria will tell you what is happening. Now, as we are, let me marry it with just 1 second, with a sagittal. So this is a sagittal. Now, you see, we are going through the nasopharynx. This is the adenoids, and this is how the adenoids looks like. We will pass through the hard palate and then the soft palate. And so this was part of the uvula, which is still visible. And you can see this high signal. So we are at the tongue base. and this is the lingual tonsil. And you can see how bright it is. So this is normal. And as we go more inferiorly, you can see this epiglottis, it comes into view. Epiglottis comes into view. And because there is a bit of motion artifacts, and there is a bit of secretion here, but you can see this glossoepiglottic fold. And you can see the valleculae here and the valleculae here. So, we just stop here because we have not learned more than that. Now, candidate 2, I'm going to show you an abnormal case, and you are going to, this is palatine tonsillar, palatine tonsil. Carcinoma. If you see here, right and left, you can see this is the palatine tonsil on right side. This is on left side. Can you ask the mouse and tell me where the tumor is going locally? I'm talking about local spread. Can you ask for the mouse, please? So the mouse is with you now.
Yes.
Can you scroll?
No, sir. I'm not unable to.
Okay, then leave it. I will go through it. Now, if you see here, this is the palatine tonsil. And as I go anteriorly, do you see the tongue here? And do you see this tissue which is going into the tongue here? Actually, I am not showing you post-contrast, but we have done post-contrast also. You can see, what I'm trying to tell you is that even without contrast, you can see the extension. And you remember the anterior pillar of the tongue. So, anterior pillar of the tonsil. And from there, the tumor has gone here. So for local staging, you will tell the, nobody is asking you in your 2B exam, it's slightly beyond 2B. But I'm just trying to give you the, this is the concept of learning anatomy using pathology. So from the anterior pillar, it has gone into the tongue. And then you can see that there is spread here and there is spread here. If I go inferiorly, you can see these lymph nodes. And you can see, look at this, which is here. This is the sternocleidomastoid. This is the lymph node which is abnormal. Actually, contralateral lymph node, this one. Level 1 node, level 1. Nodes we will cover next time. But you can see all of these are abnormal. So this is oropharyngeal carcinoma, which arises from the tonsil and then invades the surrounding structures like this. Okay, then, so we this patient, candidate 2, can you hear me?
Yes.
Now, if you see here, this patient presented with lymphadenopathy. And the patient basically presented with swelling neck. And they did an ultrasound which showed that it is malignant. And then on this, these are malignant looking lymph nodes. Where is the primary? This is the question for you.
Left nasopharyngeal.
Excellent. So you can see that this is the primary, which is the nasopharyngeal carcinoma, and it's a known site of hidden tumors. From here, we come to retropharyngeal space. Now, Retropharyngeal space is a potential space. Basically, what are the contents? The contents is usually fat, and in the suprahyoid region, there can be lymph nodes, lateral and medial lymph nodes. But the extent of the retropharyngeal space, please remember, is from the skull base till D4. It goes all the way into the mediastinum. So that is the importance. And in infrahyoid, there is only fat, no lymph nodes. Retropharyngeal space is an exam case. It will come in your exam so often. Retropharyngeal, abscess and things like that. So, key point to remember is that usually abscess is because of lymphadenitis, and it is superior to the level of the hyoid bone. Inferior to that, there is no lymph node. Now, if you look carefully, you see this structure here where I am pointing out, this yellow structure is the retropharyngeal space, and they have shown small lymph nodes also there. Now, you have to discriminate it with the perivertebral space. So the key point is that this muscle here, which is the prevertebral muscle, is known as the longus colli muscle. So I'll show you how do you discriminate between these two entities. So here again, at the level of the thyroid gland, you can see the retropharyngeal space. It is full of fat. And look at these muscles. These are posterior to that. Now, the concept which you have to remember is, I don't want to go into the details of the, the concepts, but the main point to remember is that retropharyngeal space abscess should be taken very seriously in children particularly, because there is a communication with another space. We call it the danger space, and in practical terms, what can happen that a retropharyngeal space can go into the mediastinum. So from the neck, it will go into the chest. So you have to take it very seriously. Now, if you see here, look here, the key point is this is the vertebra. There is a muscle here. There is a muscle here. We are at the level of the oropharynx. And we can see the tongue here. And this is the palatine tonsil. If you look carefully, you can see this fat here. And this fat is anterior to this muscle. Anterior to this muscle. So this is retropharyngeal space. Slightly inferior to that, another level where you can see this is the retropharyngeal space. And further inferiorly, you can see this retropharyngeal space. Now, as you an mass or an abscess or whatever, and you can see that it is anterior to the prevertebral muscles. So this is how you discriminate it. Another picture which tells you that this is how you are going to diagnose that where it is. It is anterior to these muscles. Okay, candidate 2, this is your viva case. This patient presented with a 17-year-old with fever, neck pain, swallowing difficulty. Now, if you see here, this is the level of the epiglottis. So you can see here, and this is the level of the valliculi, glossoepiglottic. Anything in the retropharyngeal space? Over to you.
There is an area of hypodensity seen in the retropharyngeal space.
Mm.
Would represent a phlegmon or a fluid collection.
Yeah. Okay, so if you see here, there is a hypodensity here. This is the longus colli muscle, hypodensity. So there is a bit of fluid there. With this kind of clinical, we should be worried about, but there is a concept of effusion in the retropharyngeal space. So sometimes there can be fluid, and it will be an incidentaloma of no significance. So that is very important for you to remember. Now, this is the principle. How do you reach a conclusion that the mass is in the retropharyngeal space? The mass can be an abscess also. You have to look at the prevertebral muscle. So this is the prevertebral muscle, and prevertebral muscle, and if it is in the retropharyngeal space, it will be anterior to that. So that is the principle. If you see here, I've given you an MR, and this is a real life, exam scenario where this patient had an MR neck, and this is a T1 weighted sequence. This is a stir sequence. There is something sitting here. Which space it is? This is the question.
I think this is in the prevertebral space.
Why do you say that?
Because the prevertebral muscles are displaced anteriorly.
Excellent. So this is, if you see here, this is the prevertebral muscle, and this is the prevertebral muscle. This is sitting here, so this is a mass arising from the vertebra itself, and it is displacing it anteriorly. But if it was in the retropharyngeal space, it would have displaced the muscle posteriorly. Now, if you see here, again, similar to the case which you saw before, this patient had, a lot of symptoms. If you look carefully, there is an enhancing lesion here, which is showing ring enhancement. This is the prevertebral muscle. So this appears to be what? What is your diagnosis?
Abscess, retropharyngeal abscess.
Retropharyngeal abscess. Any pertinent positives?
Not sure.
Okay, one thing which I wanted to emphasize is that whenever you see in head and neck any infection, when you are looking at the brain, always look at the sinuses, sinus thrombosis. In neck, always look at the veins. Is there jugular vein thrombosis? And in this particular case, if you look here, you can see that this is the jugular vein. Do you see this?
Yes.
There is a thrombus. And there is a concept of acute thrombophlebitis. When there is acute thrombus, for about a week or so, there will be a lot of inflammation, and you might see this enhancement, etc., as we are seeing it here. And after that, it will become chronic. So the point is that this is a retropharyngeal abscess with jugular vein thrombosis. The learning point or the teaching point is always look at the vein whenever you see anything in the exam or in your day-to-day. Yes, please. Normal, abnormal?
Abnormal, there is prevertebral soft tissue thickening.
Excellent. So if you see here, this soft tissue is all thickened or widened, and you don't have to measure anything. And this is also a retropharyngeal abscess. So this is the retropharyngeal space. And the key thing which, abscess is crucial to avoid delay, as this may cause airway compress and extend into danger space. Remember that. And it will go into the mediastinum. So it is if you miss it, it's a bad miss. And beware of a normal variant which has got effusion. And I've seen quite a few cases in which we overcalled it. And then the clinicians came back to us. We call it an abscess. At times you will see an abscess without any enhancement, by the way, in the retropharyngeal space. So we called it an abscess, and they said, oh, the patient is absolutely fine. And the answer is this. So there is an entity, we call it effusion, and it can be due to lymphatic drainage, impaired lymphatic drainage and all of these causes. Now, let's see this. Now, if you see here, wait, just 1 second, please. 11.2. Now, so if you just concentrate on this T1, can you see this DICOM image, candidate 2?
Yes.
So the idea here is to look at the retropharyngeal space. In this particular example, there is a bit of fat. In each and every case, there might not be fat. I showed you a CT also with fat. So this streak here is fat, and this is the longus coeli muscle. This is the longus coeli muscle. So this is the fat we are talking about, and this is the retropharyngeal space. If you see on the stir sequence, you can see it as a black line, and which tells you that it is fat saturated. So this is the fat, just touching the prevertebral muscle. I'm gone into the larynx here. So still fat and fat. So I'll show you a case of diffusion. Now, if you first of all, if you go to this sagittal and just look at this, it looks horrendous, isn't it? Tells you the anatomy very well. You can see it touches the base of the skull, and all of this. Candidate 2, you can see my mouse, the sagittal view.
Yes.
And you can see fluid here. So you will immediately jump, oh my God, is it an abscess there? It will be horrible if it is an abscess. And this patient was asymptomatic. And the point to remember is that there's an entity, we call it effusion on this axial. You can see it. And now this is that longus coeli, and you can see this fluid going around it. But please remember that this fluid can go all the way down and then go into the mediastinum. So you can see my PowerPoint?
Yes.
Right. So, of course, in the retropharyngeal space, there can be lymph nodes, etc. These are from your Chapman. There is a differential diagnosis of retropharyngeal focal masses. Most common is lymph node, of course. And then there will be, of course, diffuse abnormality, which was that fusion type of example. Okay, candidate 2. Long case from the exam. This patient had a history of colectomy 20 years ago. 42-year-old female, patient is quite young, isn't it? And she had a total colectomy 20 years ago. With that background, what is happening here?
In
And
the left,
yeah,
in the left prevertebral region, there is a T2 hypointense, minimally enhancing, and T1 hyperintense.
I have not given you post-contrast sequence. This is T2, 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 T1. So this is low signal on T2, right? And
Yes.
if you compare this muscle, basically what has happened is that it is something within the muscle. Muscle has expanded, and unique signal here. It is low signal on T2 weighted sequence. You know, usually pathologies are intermediate or high signal on T2. So, and this patient also has got this.
This is Gardner syndrome.
Excellent. So in Gardner syndrome, what happens is, Gardner syndrome is a very important, you know, we did when we covered GIT, we covered it. And in Gardner syndrome, of course, the patient will have familial adenomyosis polyposis, and we know that these patients will have a colectomy at the age of about 20 or so. Otherwise, it is pre-malignant. And there are other entities which can happen. One of the entity is osteoma of the skull and PNS. Another one is desmoid tumors. And desmoid tumors can be at any place, in many places, mesentery, abdominal wall, soft tissue. So the key point is that desmoid, remember the word, just like a fibroid, it will be low signal on T2 weighted sequence. So that was another example. This is not what we were doing, but can you tell me which facial compartment this lesion is? Which space is this lesion?
So the posterior cervical.
Okay, mostly posterior cervical. And is it going into other compartments? I have not given you everything, but let me tell you that it was going into other compartments also. Now, with this background and this kind of radiological features in a 6-year-old, what comes to your mind?
Lymphangioma.
Lymphangioma. Okay, good. So the point is that this is a differential diagnosis, which is transspecial neck lesions. So these are lesions that readily cross facial planes in neck, two groups, congenital lesions and aggressive process which break through fascia. So venous malformations or veno-lymphatic malformations, previously we used to call them, look at this word, lymphatic malformation. Previously we used to call it a cystic hygroma also, but now this is the terminology which we use. So I just wanted to cover this differential diagnosis, otherwise we were not covering it. Okay, from here we come to larynx. Now, larynx is sitting in the infrahyoid neck. And in infrahyoid neck, we have got multiple spaces, and larynx is part of the visceral space. So if you see here, the visceral space, it rises from the hyoid bone to the mediastinum. And it has got thyroid gland, parathyroid gland, larynx, trachea, hypopharynx, esophagus, recurrent laryngeal nerve, and lymph nodes. So this is the thyroid gland, parathyroid gland. This is the trachea. This is the esophagus. These are muscles which are, look at the name sternohyoid, sternothyroid. These are the muscles which are known as strap muscles. Now, please concentrate. So we have come, to the larynx, the main part and of our session today, larynx. And you have to now really concentrate, and then we will, what we have learned in the pharynx, we will combine it together and then we will consolidate it. If you want to understand the larynx, first of all, you have to understand the endoskeleton or the framework of the larynx. And on this framework or endoskeleton, the larynx is built. Key thing is the laryngeal cartilages. The four cartilages which are important are, one is this thyroid cartilage, second is cricoid cartilage, then of course is the epiglottis, which is quite unique in shape, so you don't confuse it with anything else, and then is the arytenoid cartilage. Don't worry about this small corniculate cartilage. So first of all, let's do the thyroid cartilage. Now the thyroid cartilage is the largest cartilage of the larynx. And this is what we call the Adam's apple. If you touch your neck right now, you can feel it here. This is the Adam's apple. Now, this is known as lamina, right lamina and the left lamina. Beware of this notch here, thyroid notch. What will happen is that if a slice of CT scan or MR goes through like this, there might be missing structure, and you will overcall it. You will think as if there is a defect there. So this notch is important for you to realize. Now posteriorly, if you see, this is the posterior view. This is the lamina. This is the lamina. So there are these superior cornu and inferior cornu. Now from the superior cornu, there is a membrane which is known as thyrohyoid membrane, which arises. This is the thyrohyoid membrane, and this is the hyoid bone. From the inferior cornu is attached with the cricoid cartilage. Then we come to the second cartilage, which is the cricoid cartilage. Point to remember, cricoid cartilage is the only cartilage which is a complete ring. Remember that. It is a key cartilage. It is a complete ring. And if when a tumor involves the cricoid cartilage, you have to do a complete laryngectomy. Otherwise, at times you can do a partial laryngectomy. If you see the shape of the cricoid cartilage, anteriorly, it appears as a ring. From below down is the trachea. So this is the ring. And posteriorly, we describe it as signet ring appearance. So this is posteriorly. If I show you a sagittal, you will understand how it looks like. Anteriorly, it is a ring. This is a signet ring. So the signet is posteriorly. So posteriorly, it is in a craniocaudal dimension, it is thicker. Here, it is not as thick. Now, the cricoid cartilage, you see there is a membrane between the thyroid and the cricoid cartilage anteriorly. Now, another point is that on top of cricoid cartilage, the arytenoid cartilage sits. And if you look at this lateral, this is very important level. This is the level of the true cords. So this is the arytenoid cartilage, and this is the anterior process of the arytenoid cartilage. And there is a ligament here, we call it the vocal ligament. And on it sits the muscle, vocalis muscle, and this is the true cord level. Now, so this is arytenoid cartilage. And then, of course, the epiglottis. So key points to remember is it gives you a leaf-like appearance. There is a free edge here, which is projecting into the oropharynx airway. And this one is the petiole. It is attached with the thyroid cartilage. Another landmark for us is that this is that hyoepiglottic ligament, This is the hyoid bone. This is the epiglottis, hyoepiglottic ligament. On top of it is what we call a mucous membrane, which is, or mucous fold, which is the glossoepiglottic fold. And this becomes a landmark which divides it into right and left valliculi. Now, this gives you, within the larynx, there are multiple muscles. These are endolaryngeal muscles. You don't have to worry, but they will give you a soft tissue attenuation. You cannot discriminate them on imaging, but the concept you should understand. So this is, we are looking from superior side, and this is that arytenoid cartilage. This is the vocal ligament, and on it is sitting this muscle. This is the vocalis muscle. And other muscles, and you don't have to even remember these names, but there are other muscles, we call them endolaryngeal muscles, which include thyroarytenoid, cricothyroid, cricoarytenoid. All of these are other muscles. But you should have a general idea that there is a muscle here, which is the vocalis muscle. Now, this diagram is very, very important, because now we are dividing the larynx into three parts. One is this is a coronal diagram, and this portion where the vocalis muscle is known as the glottic level. So this is the glottis, or the true chord level. So this is glottic larynx. Superior to that is the supraglottic, and inferior to that is the subglottic or infraglottic larynx. There can be tumors which are sitting in the glottic level. There can be tumors which are sitting in two levels, and there can be transglottic tumors which are on all of them. Now, on this diagram, you have to learn some more names of vocabulary. And after this, I'll give you a break. Now, this is the supraglottic larynx. We will learn, how do we divide it and things like that shortly. But the airway inside is known as vestibule. This word should be in your vocabulary, vestibule. What is vestibule? It is the airway inside in the supraglottic larynx, vestibule. Then look at this mucosal fold where I'm pointing out. These mucosal folds makes this vestibule attenuated, right? So the airway will be slightly different shape here. And this is known as false chords. Inferior to that, if you see here, there are two extensions or sinuses which are known as ventricles. So don't confuse the word ventricle with vestibule. This is ventricle. And ventricle, there is a entity, we call it laryngocele, etc., where so you have to understand that it will be expansion of this ventricle. And then is the true chord. Inferior to that is the infraglottis, which includes the cricoid cartilage, and then will be the trachea. So these are the three levels. Here, once again, vestibule, false chord, true chord, and this is ventricle. Now, look at this fat. You remember there was fat anterior to the epiglottis, which is known as pre-epiglottic fat. It is in continuity with fat here laterally, which is known as paraglottic fat, and on imaging you can see it. This paraglottic fat ends at the level of the true chord. So this is the coronal section. Okay, we stop here and we will continue it after 5 minutes. And candidate 3, you will take over. Thank you very much, candidate 2.
Thank you so much.
Candidate 3, are you with us?
Yes, sir. I'm here.
Okay, very good. So we'll continue with a bit of lecture mode before I show you a few cases. Now, you remember that we learned in the previous, before the break, that larynx has got three portions: glottis, supraglottis, infraglottis. Let's see a few further landmarks. On this, we can see that this is, of course, the thyroid cartilage. This is the arytenoid cartilage. And we can see that this is the true cord level. Here, this is the cricoid cartilage, and this is the anterior ring, the signet ring. Now, this is the epiglottis. This is the hyoid bone, thyrohyoid membrane, which is this one. Now, this thing we have already learned. This is that glossoepiglottic fold, within which is the hyoepiglottic ligament, and this is the landmark which divides the supraglottic, into right and left valliculi. There is another mucosal fold here, which is known as pharyngoepiglottic fold. Now, key fold is this one. This is the arytenoid cartilage. From here, a mucosal fold, it goes the aryepiglottic fold. This is a key fold. Now, what happens is that aryepiglottic fold, by definition, is a part of supraglottic larynx, but the wall, which is the posterior wall, which is hidden from our view here, is considered part of the hypopharynx. So, key point to remember that aryepiglottic fold is basically considered part of the supraglottic larynx, but the posterior wall is considered part of the hypopharynx. This, of course, is still supraglottic larynx. Now, here, because of this glossoepiglottic fold, the valliculi and the valliculi right and left, they, of course, are air-containing structures. They will be part of the hypopharynx. However, this fat, which is the pre-epiglottic fat, is by definition part of the supraglottic larynx. And I told you here on the previous diagram that pre-epiglottic fat also is in continuity with paraglottic fat. So once again, this is the glottic level. Superior from here till here is the supraglottis, till this fat. Superior to the fat is the oropharynx. By definition, epiglottis is considered part of the supraglottis. Posteriorly, aryepiglottic fold is the boundary between the supraglottic larynx and the hypopharynx, which of course is hidden from our view. Inferiorly, inferior to the true cord level, from here till here, is the infraglottic larynx. So, same thing here, and this is the false cord. Now, so this, on a barium examination, this is what happens, that if we see an AP view, this is the glossoepiglottic fold, which is this one, and this is this one. Right and left, there is air space. This is valliculi, and on a diagram or CT scan, it will look like this. So by definition, valliculi is a part of the oropharynx. It is just sitting posterior to the tongue base. And this, on the other hand, the barium here is in the piriform sinuses. And piriform sinuses, by definition, are portion of the hypopharynx or the laryngopharynx. So this anatomy is also important for the exam. So Once you learn this, then you can make sense. Veliculi are anteriorly and piriform sinus are posteriorly. Veliculi are part of the oropharynx. Piriform sinus are part of the hypopharynx. Ossification of the laryngeal cartilage. Please remember, this is the concept. Even after the age of 30, sometimes the cartilage, they start become ossifying. And in old age, you will see them like this. So don't get confused. On an MR in a young child, it gives you a soft tissue mass type of an appearance. On an MR of an old patient, it gives you much better view, particularly on the T1, because it will be high signal on a T1. So this is the concept of ossification of the cartilage, and you will confuse it when particularly you are reading cases, A&E films of fishbone, that kind of history. At times it might be difficult for you to discriminate. And I've seen cases where in young patients, I told you that sometimes ossification can happen at the age of 30. And people have overcalled it, I'm worried about a foreign body. So please remember, it has to be correlated clinically, but you should understand that ossification at times, particularly of the arytenoid, can happen in quite a young age. Okay, now I'm going through a series of images now, and these images are the key images where I will show you an axial diagram followed by a CT scan. So axial diagram followed by a CT scan. And if you see here, this is the level of the epiglottis, and this is the glossoepiglottic fold, the veliculi, both of them, the pre-epiglottic fat, and this is the hyoid bone, and this will be the paraglottic fat. Now, posterior to the aryepiglottic fold, this thing is the hypopharynx. Hypopharynx, this is the posterior wall of the hypopharynx. This is the piriform sinus and the piriform sinus. So these are now on a CT scan. This is it. Glossoepiglottic fold. Look at this, the orientation. The slice is going like this. So glossoepiglottic fold, hyoid bone, pre-epiglottic fat is still not in the view, but next slide, it might come into view. And this is the epiglottis. The piriform sinus is just coming into view. Next slide. Now on next slide, this is that hyoepiglottic ligament. Of course, in a diagram it looks very good, but you won't see it on radiology. But just to make a point, this was this ligament, right? Hyoepiglottic ligament, which was within the glossoepiglottic fold. And now the pre-epiglottic fat has come into view on this diagram. The piriform sinus and the piriform sinus is there. So look at the CT. On this CT, now you can see pre-epiglottic fat. You see this thing? It is passing through the fat. This is the hyoid bone, piriform sinus, piriform sinus. Now this is the aryepiglottic fold. Next slice, we will start seeing it much better. Now, this is another level, next level. Now we can see the thyroid cartilage. This is the paraglottic fat. And don't get confused with this airway where the diagram, this is the true chord level. So right now the airway will not be like this boat. But the aryepiglottic fold, which is this one, is visible now. And this is the piriform sinus. This is the posterior wall of the hypopharynx. So CT scan. Now this CT scan is just below that level, what was visible on that diagram. Actually, it is at the true chord level. Look at the airway. And this is how you discriminate, or you can discriminate. It's not boat shape. At the level of the true chord, the airway will be boat shaped. But here you can see the pre-epiglottic fat is still visible. The paraglottic fat and the paraglottic fat will be here. Stretch of imagination, because there is no air. the piriform sinus and the hypopharynx is now completely collapsed. So next slice. Here you are. Look here. Key point. If I always say that in laryngeal imaging, if you ask me, please tell us one tip in laryngeal imaging which will help us to orient ourselves. The tip is that look for a slice where you can see two cartilages, one on top of other. And this is the only slice. How? If you see here where you can see two cartilages, this is the cricoid cartilage. Anteriorly, this is the arytenoid cartilage. When you see two cartilages together, you should know that you are at the true chord level. So this is the key tip to remember. And now, if you see the airway is boat shaped. This is known as anterior commissure, where the true chords, they meet anteriorly. This is the posterior commissure. Posterior commissure is the mucosal surface on the cricoid cartilage in between the two arytenoid cartilages. If we do staging of laryngeal carcinoma, we measure this soft tissue, and there are some rules. It should not be 1 millimeter or more than that, but you don't have to worry about that. So, but the paraglottic fat continues. Look at the piriform sinus. It is still, it is becoming a bit attenuated. So look at the CT. Now, this is what I was talking about. Two cartilages, one on top of other. And it makes sense. If you see here, this is the cricoid cartilage, this is the arytenoid. And at the true chord level, the slice goes through it. So part of the arytenoid and part of the cricoid will be seen. Whenever you see two cartilages, you should immediately know that you are at the true chord level. And please remember that if the patient, this airway is only visible if it is in abducted position. Adducted true chord, you don't see that. But the principle is very important. We will come back to this point shortly. This is the hypopharynx, which is collapsed. This is the thyroid cartilage. Now, this is the concept of motion. True chord, when patient is respiring, we see it like this. If you take a CT in held respiration or phonation, phonation is where you ask the patient as you scan, just to do like this, and automatically this will be adducted. So the classical method to do a CT scan, we call it a CT of laryngeal protocol. Please remember, for staging of lung laryngeal carcinomas, MR is the investigation of choice, because MR shows you cartilaginous invasion much better than a CT scan. And if the cartilage is involved, we call it T4 tumor, and you might change it into a, let's say, a total laryngectomy, things like that. Having said that, 20% of patients who have got laryngeal carcinomas might not tolerate the study for the simple reason that it's old age, and usually because of the tumor, they are swallowing during the examination and things like that. Similarly, many centers might not have MR or the capacity to do MRs. So CT is a very good modality. And the beauty of CT is that you can do it in two phases. One is, this is a classical CT of the neck, where you cover from the base of the skull till the clavicles, give IV contrast. And the teaching is that if you do 90-second delay, just remember that 90-second delay is considered the best. There are some studies which are published on this. 90-second delay, and you won't go wrong. The jugular vein is very well seen. And do this, and the second phase is held respiration or phonation. Here, you just cover it from the mandible till the inferior to the cricoid. And here, you will get this. So indirectly, you can get the motion of the cords. You can document the motion of the cords. You cannot do it on MR. Remember that. So this is CT laryngeal protocol. When it is not designed, many a times you will get this kind of airway, and you will be looking, oh, where is that port? So don't worry, the scan has been done in held respiration. Key reference point is these two cartilages. Where you see these two cartilages sitting on each other, you know that you are at the true cord level. From here, we go to the next level. In the next level, we are, the cricoid cartilage is coming into view. And posterior to the cricoid is what we call the postcricoid hypopharynx. And please remember that at this level, the esophagus also starts. So, and you cannot discriminate it into on radiology where the hypopharynx finishes and the esophagus starts. Having said that, look at this. The trachea is here. Now there is no fat. You see, more superiorly, there will be fat. Paraglottic fat ends at the true cord level. Here, at the level of the cricoid, there is no paraglottic fat. Number two, the airway is, there is no soft tissue in the airway. So if there is soft tissue, that will be a tumor. And this is how you see it on CT scan. So we are passing through this bit. Posteriorly, the signet is, you are passing through the signet. Anteriorly, the thyroid cartilage is still in view like this. And you can see part of it is ossified. And look at the airway. I go back, look at the airway versus here, it becomes oval. And then this diagram tells you that now more complete ring, and anteriorly this area where the membrane is there. So it will all look like, because of ossification, if it was ossified, you would have seen it as a white structure. Otherwise, you will see it as a soft tissue structure. On the other hand, now thyroid gland has come into view, and this is the esophagus. So this is the thyroid, and this is the trachea, and this is the cricoid. So, of course, this is the thyroid, and this is the trachea. So now we are inferior to the level of the cricoid, and we are in the trachea. So we will see a CT and we will see an MR. So the main pathologies in larynx, the most important is, of course, a tumor, as in laryngeal carcinoma. Laryngocele is another one which you have to remember. Basically, what happens in laryngocele, that there can be air or a fluid-filled cystic dilatation of laryngeal ventricle. You remember the ventricle which we considered, and it may be contained within larynx. If it is within the larynx, we call it internal laryngocele. If it goes through the thyrohyoid membrane beyond the confines of larynx, we call it external laryngocele. Usually due to increased intralaryngeal pressure, for example, chronic cough or occupation, glass blowers or instrument, musicians, etc., they can develop these laryngocele. So SCC is important, laryngocele is important. Another thing which is important is other lesions, because these are lesions of visceral space. This is just for larynx. So thyroglossal duct cyst, parathyroid adenoma, we will see them subsequently. Okay, let me go through these two CT scans, and then we will, the first Viva case is coming after these. Candidate 2, can you see the DICOM viewer? Correction, candidate 3.
Yes, sir, I can see.
So I might ask you a few questions also, candidate 3.
Okay, sir.
So we have done a two-phase CT scan in this case, and we will just quickly go through. So we are. Let me just 1 second. Let me put a sagittal here also. So we are in the nasopharynx here. Now we are coming here. We are passing through the soft palate, the oral cavity. There is a bit of dental artifact. Now, what is this, candidate?
Epiglottis, sir.
Excellent. So epiglottis, and you can see it here, but on an axial, you can see it here. It is projecting into the airway, oropharyngeal, and in this particular case, a bit of stretch of imagination that the valleculae are like this, and then we come at this level. What is this structure where there is low density?
This is the fat, the pre-epiglottic fat.
Okay, and what fat is this?
Continuation of the pre-epiglottic fat along the lateral aspect.
So this one is known as paraglottic fat. So this is paraglottic fat, and this is pre-epiglottic fat. This is the hyoid bone. Now, what is this structure?
Piriform sinus.
Okay, excellent. Now, what is this structure?
This will be the false cord. Aryepiglottic fold.
Aryepiglottic. So this is the piriform sinus. So this is the aryepiglottic fold. And you can see that this is the pre-epiglottic fat, and it is continuity with the paraglottic fat. Now we are going more inferiorly. Here, the aryepiglottic fold is once again visible, the piriform sinus, and look at this fat is in continuity. Now, this is the true cord level, true or false?
No, sir, because I can see fat anteriorly.
Excellent. So here, fat anteriorly, other than that also, if you see
boat shape,
boat shape, but another thing which I told you, two cartilages.
Yes, sir. Two cartilages are not there.
Not visible. Now I am going inferiorly, and now you can see.
Yes, the two cartilages.
So these, what cartilage is this?
This is arytenoid. And cricoid. This one cricoid posteriorly.
Right. So now you can see this boat shape, and so these two cartilages are critical. So I go back, and you can see that both of them are out of our view. So this is the type of airway which you see at the level of the false cords, right? And and then when it is at true cord level, you will see two cartilages like this, and it will be boat shape. Now this is the thyroid cartilage. Now arytenoid cartilage is just getting out of the view. So this is, what is this cartilage?
Cricoid.
Right. We are at the undersurface of the true cord. So right now we are looking at undersurface, and now as soon as the undersurface is gone, you will see this oval, airway, and this is at the level of the cricoid. Cricoid is still visible. Cricoid is still visible, and you can see the thyroid lobe coming into view, which is high density, and now that is gone. And you remember there was a ring anteriorly, and now you can actually see the ring here where I'm pointing out. And then next slice, it is gone. And now this is thyroid and this is trachea.
Thank you.
Now, just concentrate on this one. Now, do you see the difference here?
Yes, sir.
What is happening?
This is during health respiration. So the vocal cords are adducted.
Excellent.
On the left side, on the right side.
Okay, very good. Now, let's go to an MR. Now, this MR is so our aim is just the larynx. So we will now, if you see this oral cavity, this is the tongue. And now we are going, this is the tongue base. And you can see on the stir sequence that there is high signal, which is the lingual tonsil. Actually, we can see the epiglottis, and we can see, what is this structure?
Glossoepiglottic fold.
And what is this black and this black structure?
Pelliculi, sir.
Excellent. So now this is the point I was making. Now look at this. We are at the level of, this is the thyroid cartilage. And look at the signal. And this is just like, you know, marrow, as in fatty marrow, because it is ossified. So in an advanced age, this can happen. This really gives you very good view. Now, if you see here, this is that paraglottic fat, which you can, if I go back up here, so this is, if you see the paraglottic fat in continuity with the pre-epiglottic fat, and it shows signal dropout on this stir sequence. Now, as I'm going inferiorly, you can see this paraglottic fat, and you can see this paraglottic fat has lost signal. Look at the airway. It is not boat shape. It is just superior. You know, this is the level of the false chord. Now, you see this thing? What is this?
Arytenoid cartilage.
Arytenoid cartilage. And what cartilage is this?
Cricoid.
And next slice, it becomes more obvious. This is the arytenoid, this is the cricoid, and you can see this boat shape. You know, the paraglottic fat continues, and next slice, actually, you can see the muscle. And this is the classical two cartilages and the boat. Now we go inferiorly. And you can see that the cricoid is like this. If I go back, you can see boat shape. Now here we are at the under surface of the cord, where the airway is changing, and then it becomes oval. And this is the cricoid. And then here, actually, we can beautifully see a complete ring. So, so you can see that if it is ossified, it can be seen very beautifully, like this. Okay, now there is a Viva film for you now. Can you visceral space lesions? Chapman slide is in. You can see this.
Yes, sir.
Okay, so this is a case for you. Over to you.
Okay. This is a lateral image.
Yeah.
Of a barium study.
So this was a gastrographin.
Okay, gastrographin. I can see that there is some contrast is going into the larynx at the level of C6.
Yeah.
Yeah, and it is going in, the area appears irregular.
Mm-hmm.
So this is likely the level of the pyriform fossa, which is appearing irregular.
Mm-hmm.
Okay. So I cannot see the tracheal cartilage in this very well. It's
Tracheal.
not
So tracheal cartilage should be,
hyoid bone is also not visible.
okay. That's a very good observation. So what does it tell you?
Likely the patient had some surgical resection.
Excellent. So now, can you put in a story now? This becomes a story film now.
Okay, so it's a post-surgical case with removal of the hyoid bone and non-visualization of the tracheal cartilage. There is some contrast.
Excuse me, tracheal cartilage. Why do you say that? You know, tracheal
Okay,
cartilage can be calcified. At times, it will not be. There is no. It might not be visible for the simple
sorry,
reason.
the thyroid cartilage. Sorry.
Thyroid cartilage. Again,
Yeah.
that's a plus minus thing. Okay, please continue.
Okay, so there is absence of hyoid bone in a post-surgical case, and I can see that there is some. Is this a tube going anteriorly?
So that was just something which is an artifact. We are not interested.
Okay,
What is happening?
and there is some the contrast in some irregular area anterior to the esophagus at the level of pyriform fossa.
So
this may be fistulous communication in post-surgical case.
and why has this been done, this procedure? You are close to clinching it.
Any inflammatory process or recurrence they want to see?
Why will be there an inflammation in a post-surgical case?
Post-surgical inflammation.
This is a long-standing post-surgical case.
Okay, so it can be done to look at any recurrence.
No, you use the word inflammation. So I said, okay, fine, there will be a sort of inflammation, but why will there be in a long
If
study?
there is a fistulous communication, then maybe the patient is continuously, whatever he's eating, it's passing into the cavity.
Why has that cavity or that fistula been produced? That is my question.
Post-surgical, sir?
No, but surgery was done years ago.
Any foreign body impaction?
Okay, let me take over. So if you see here, this says post-total laryngectomy appearance, and this is an important exam case. It has come in the exam. It has come as a CT scan also. And the point is that in post-surgical case, what happens is, first of all, it is what we call a story film in FRCR exam. The film tells you a story, and you have to develop your story. The story is that, first of all, you have to understand that this is post-laryngectomy appearance. And then you have to piece together that what happens. Now, this is normal. Periepiglottic fold, veliculi, piriform sinus, veliculi, piriform sinus. Now, what happens? Basically, you will, first key point is that hyoid bone will not be visible. And this is the hyoid bone here, and which is missing here. This is another case. It will give you a featureless, smooth, inverted appearance, inverted V-like appearance, which will be featureless. That is the key. There are no veliculi, there is no piriform sinus. So from here you can understand that this is. Then what happens that usually these patients they get radiotherapy, And radiotherapy produces chronic inflammation. The theory is that it causes small vessel vasculitis. And years down the road, the patient will have fistula. So, this was a fistulous communication with the skin, simple as that. So this is post-total laryngectomy appearance. Now, with this thing, I'm going to show you a case, which if you see here, we are at the level of the pre-epiglottic fat, and then there is something happening here, and we go down. So I am going to ask you leading questions. Now I'm going to show image after image.
Okay.
What is this structure?
The pre-epiglottic fat.
Okay. What do you think?
This is the level of the vestibule.
Vestibule? No.
Ventricle. No.
This
Okay, this is the hyoid.
Yes, this is an abnormal case. So I'm going to go through it and I'm going to ask you questions on this. This is an abnormal case. So this is the hyoid bone, pre-epiglottic fat. Now, what is happening here?
Asymmetric thickening on the right side.
So what are you worried about?
The fat plane is preserved anteriorly. I would be worried about any neoplastic disease process.
Why?
But
Fat plane is preserved.
Fat plane is preserved, so it yes. But I will still have to look more closely to rule out any neoplastic disease process.
Let me correct you here.
Yes, sir.
This idea that fat plane is preserved, there is an entity, we call it fat plane is displaced. Here, what is happening is that there is a lot of fat in this area. And
Yes.
you can see this paraglottic fat, and there is some soft tissue here, which is actually, if you see what is the epicenter here? What is this structure? Compare with normal side here.
Yeah, this is the pyriform fossa on the left side, the normal one, and on the right side there's a soft tissue thickening and the aryepiglottic fold.
Right, very good. So the aryepiglottic fold is thickened, right? Now,
Yes.
with that thickening, there is a soft tissue mass there. That
Yes.
mass is extending into the pre-epiglottic fat here. On the right side, it is extending into the paraglottic fat here. Paraglottic fat.
Yes.
And now we are going inferiorly. We are heading towards, if you go back, now these were two aryepiglottic folds. Now
Yes.
we are going more inferiorly. So which level are we, right now?
This is the false chord level.
False chord level. Now
Yeah.
you can see that the tumor this is the tumor. It is invading the paraglottic fat. We are going inferiorly. Still, we have not reached the level of the now. Do you see two cartilages? One cartilage.
Yes.
And next slice, now you can see two cartilages.
Yes.
So we have reached the true chord level. And the next is, so the tumor has extended into the true chord level. With that, do you see this sclerosis?
Sclerosis, yes, sir, of
What
the
is it?
right arytenoid cartilage.
What does it mean?
It means that it has involved the arytenoid cartilage.
Right. So this is taken as a sign of involvement or invasion of the cartilage on a CT scan. The problem is that the sensitivity is, or the specificity is not very good. And another concept is that it is because of inflammation. So sometimes it is true invasion, sometimes it is not. But if you have got a CT scan and you see sclerosis like this, you will have to call it and you might be wrong. And that is why people do MRs. Now, we are going more inferiorly. So this is the true chord level. Now, if you see here, where are we level-wise?
This is the cricoid now. And anteriorly, this is the, we can see the thyroid anteriorly.
So
And
this
posteriorly, the arytenoid is, Yes, this is the subglottic space.
Yeah, but the key point I am making a bit of fine touch here is that this is what we call the undersurface of the cord.
Undersurface of
Yeah,
the glottis.
yeah.
Yes.
Undersurface, you are right that we are heading towards the infraglottic, but this is undersurface. So the tumor is projecting here. Now, next slide, you know, it has to become oval, right?
Yeah.
And what do you think? Is there a
It
tumor?
is still involving on the right side. Yes.
What is your conclusion?
The left side. So the lesion is transglottic. It is going from the supraglottic to the involving the glottis and reaching infraglottically.
Yeah. So if you see here, this is it. Even here, you can call it, because you know this subtle indentation here means there is a tumor, and this is a transglottic tumor. A bit of repetition, but I am going to show you a DICOM case now. This case has not been done with the laryngeal protocol. It is just a neck, what we call single phase study. Just concentrate from here downwards. So if you see here, we are at the nasopharynx here, and we are at the oropharynx here. There is lingual tonsil, which is quite prominent. Now this is the pre-epiglottic fat, and we are here. Just 1 second. I think there was a better phase. Let me, just 1 second. In any case, yes, we have got a single phase only. So can you ask for the mouse?
Yes, sir.
Have you? Yeah.
I've requested, yes.
Okay, take over, please.
Okay. All right, I can move it now.
Yeah. So just concentrate on the larynx, and there is a tumor. Describe the tumor and the extension.
Okay, sir. Okay, so there is a soft tissue mass noted on the left side of the larynx.
Left or right?
Oh, sorry, right side of the larynx. It is, this is the level of the true cord. So it is seen extending anteriorly as well.
Show me the superiormost extension. Is it going to the supraglottis? So where is the false cord level?
This is the paraglottic, paralaryngeal fat.
Yeah.
And
paraglottic and paralaryngeal is the same thing. Yeah, these are synonyms.
Okay. And this is the level of the false cord because I can't see the two cartilages here.
So is there
And
this level?
This is the abnormal soft tissue densities extending supraglottically.
Excellent. Now come down to the level of, okay.
Yeah, this is the level of the true cord, as I can see two cartilages. And this area anteriorly, but I'll have to trace it from above.
Down, keep scrolling.
Yeah, this is the mass, and I can see the arytenoid cartilage. And just as I see the two cartilages, I can still see, I can see it's fading actually. Okay. This is the asymmetric density here at the level of, this is the cricoid cartilage now. So this will be the undersurface of the glottis.
Continue.
Yes. Okay. Now, yes, it is involving because I can see that it is causing airway narrowing on the right side. And
so in conclusion,
it is again a transglottic mass which is involving the glottis extending supra and infraglottically.
Okay, very good. So if you let me go through this case once again, you have done very well. So we are here, pre-epiglottic fat, hyoid bone, the paraglottic fat. Now this is the level of the false chord. Here the tumor comes into our view, and so paraglottic fat is invaded. And just now we are able to see the first slice where we are able to see the arytenoid cartilage. Arytenoid cartilage is visible, and now the cricoid is also visible. So we are definitely at the level of true chord. Now what is happening here is that anteriorly, actually the tumor is passing through the anterior commissure and going to the left side. Even here, you see this.
Yes, sir.
Here and here also. This anterior commissure should be, please don't move the mouse. Now I'm moving the mouse. So here, this is the anterior commissure, and it should not be more than 1 millimeter, by the way, if the scan is in proper position. But you have to angulate the, it 10 degree towards the feet. Having said that, nobody is expecting you to pick up these things in your FRCR exam, but just a bit of, you should be able to diagnose a tumor there. And with that, nobody is stopping you to ask for a bone window, particularly to see if the cartilage, and particularly if there is some, what do you think is happening here, for example?
Yeah, there are some fine erosions seen.
Yeah. So if it is ossified, ask for bone window also. So this was, and now under surface, as soon as we go down, this is the undersurface of the cord where the tumor is projecting here. But now definitely in the supraglottis, this airway should have been complete round, and it is not. So this is it. Okay, well done. Here, there is a tumor. Let me go through it, and you will tell me where is the tumor. Location is the thing which I am asking. What is this structure?
This is the epiglottis.
So the tumor is here.
In left.
And the tumor is here. Tumor is here. Yes, please.
Left piriform fossa.
Excellent. So is it a laryngeal tumor or a hypopharyngeal tumor? Question.
It will be a hypopharyngeal tumor now.
Excellent. Please remember that supraglottis tumors will cause lymphadenopathy, glottic and infraglottic. There is a bit of embryology there. It will usually no lymphadenopathy, but hypopharynx, there can be lymphadenopathy. What is happening here?
This is the laryngosele, air-containing laryngosele.
Yeah, so this is the last case of the day. Basically, in laryngoceles, look at this diagram. What happens is that there is dilatation, usually as I showed you from Chapman, that, this ventricle becomes dilated, and there might be some adhesions, etc. Sometimes, by the way, there are tumors. Now, once it is dilated, then it will contain air. Internal laryngocele will stay within the laryngeal endoskeleton, but the external, what happens is it penetrates the thyrohyoid membrane and it goes out. So this is a simple laryngocele, just containing air. But sometimes it can have fluid inside. Trapped fluid can be inside. And sometimes what happens is that it can become infected. And then it will be a pyolaryngocele. So now we stop here. Thank you, candidate 3. I have got something for the chat now, and we are doing a final practice here now. So what I have done is that we will go through the levels here. It is designed for the chat, so everybody can participate and do a final rehearsal on your anatomy. So this is a quiz. Candidate 4, can you see quiz neck levels? Sorry, candidate 3.
Yes, sir, I can see.
Okay, so now this is open for the chat. So we will go through now. This is a revision of whatever we have done today. And after this revision, tomorrow you can go to in your departments and go through it once again. So these are the levels which I call level. Level 1 is nasopharynx. We are passing through nasopharynx. Level 2 is palate, and it all depends about your patient. It might be a bit drooping here, and you might get slightly different than what you learn here. Then is what I call it oropharyngeal level, where we are passing through the tongue. Then level of epiglottis, where posteriorly the epiglottis will be visible. And then the valliculi, the level 5, where the valliculi will be visible. Then the supraglottis level, which is the false chord level. Then the glottis, which is the true chord level. And then infraglottis level, where the cricoid cartilage will be there. And finally, the trachea. So these 9 scans, and open for chat. Number 1, please. So it is open for everybody. I hope that the chat is working. Yeah, very good. Number 2, this airway. Very good. Number 3. Excellent. So these are the answers. And this is the level, and these are the answers. This is the cartilaginous portion of the eustachian tube. It opens here. Next level. Number 2. Okay, so number 1 is alveolar ridge of, and number 2 is uvula or soft palate, and number 3 is excellent. So this is the level, and we can see the answers here. Well done. Third level. What is number 1? Okay, there is a muscle here, longus colli. Okay, which airway? Oropharynx. What is this, number 2? Excellent. And what is this slightly high density? Lingual tonsil. Very good. Level 4. What is number 1? Tongue. Okay. What is this? Number 2. Epiglottis. And what is this? High density posterior to the tongue. Excellent. So lingual tonsil, tongue, and epiglottis. Next level. What is number 1? Hyoid. And what are these? What is number 2? And number 3? And number 4? Yeah, correct answers. hyoid bone, epiglottis, valleculi, and just coming into view, the piriform sinus. What is number one? This thing. And this airway, number two, okay. Number five, collapsed. It is collapsed here. Esophagus cannot be at this position. Esophagus will be, post-cricoid, right? So these are the answers. So this was the vestibule, and this is the supraglottic larynx, and this is the false chord, piriform sinus. Third last level. What is number one? True chord. Number two, thyroid cartilage. Number three, cricoid. Number four, arytenoid. Very good. And what is here? This collapsed thing, soft tissue. Number five. Excellent. So these are the answers. And then second last, what is number one? Cricoid. What is number two? Number two, this airway. So trachea will be inferior to the level of the cricoid, right? So this is the infraglottis. And then number three, thyroid, very good. And number four, yeah, so this is the post-cricoid hypopharynx, if you want to call it. And you don't know if the esophagus has just started. You cannot, so just call it post-cricoid. And please remember, there is an entity, we call it post-cricoid carcinoma. So this is the final level. And where are we now? Number one, so there is a vessel here, anteriorly placed vessel. It's a vein. What is this? Yes, anterior jugular. Okay, good. What is number two? Number two is a vessel. So which carotid? Is it the common carotid or the internal carotid? Okay, people have answered that question. Number three, where are we? Trachea. Number four, thyroid. And number five, is esophagus. So well done. We are through with today's session.